Welcome to the digital seminar series organized by the Statistics Assessment and Data Management Core, a part of the HIV Center for Clinical and Behavioral Studies at the New York State Psychiatric Institute and Columbia University.
Hello, this is Susan Tross, and I'm going to be speaking to you today about mixed methods research, indications, approaches, advantages, and findings. What we're going to talk about is on this slide. Mixed methods, what is it? Why do it? What to do, or the methods in mixed methods. What to do, or the mixed methods design in mixed methods. What to do, the mixing in analysis and synthesis of mixed methods findings. Who and what is needed to do it. What to prepare for, the challenges of mixed methods research, and what it has added, mixed methods findings in HIV biobehavioral research. Very importantly, there is a wealth of material that is very accessible to you on the internet and in text form. And these are the foundational sources on which this talk is based. Very importantly, Dr. Cresswell is a major figure in this area, and you can see the other folks as well who are extremely important. I won't go over each reference in this slide, but I would really urge you to go to these sources. So what is mixed methods? People have said it's the class of research where the researcher mixes or combines quantitative and qualitative research techniques, methods, approaches, concepts, or language. And today we will be emphasizing the mix of quantitative and qualitative, but of course there are many other types of research that could go and do go into mixed methods. Its logic of inquiry includes both the use of inductive or discovery of patterns and deductive, the testing of theories and hypotheses, and abductive, uncovering and relying on the best set of explanations for understanding one's results. Mixed methods research also is an attempt to legitimate the use of multiple approaches in answering research questions, rather than restricting or constraining researchers' choices. It is an expansive and creative form of research. It is inclusive, pluralistic, and complementary, and it suggests that researchers take an eclectic approach to method selection and the thinking about and conduct of research. What is most fundamental is the research question. The research method should follow research questions in a way that offers the best chance to obtain useful answers. When do we do mixed methods research? Why do it anyway? When there is a call for real-life contextual understandings and multi-level perspectives, and when we want to and need to pay attention to cultural influences. When there is a call for both rigorous quantitative methods to assess magnitude and frequency of constructs, and also when there is a call for rigorous qualitative methods, exploring the meaning and understanding of constructs. When there is a call for multiple methods, and when there is a demand to intentionally integrate or combine multiple methods because we want to draw on the strengths of each. And mixed methods can align with the demand to frame investigations within a particular philosophical and or theoretical position. And you will see all of this in a little while with some real-life examples. Why mixed methods? What do we want to get out of mixed methods? First, to provide a multi-level approach to investigate complex and emergent health problems, where we really need this combination of techniques to understand something previously unknown and complicated, to characterize behavioral factors contributing to illness or health, to obtain data proceeding from a range of theoretical perspectives, so that we're spanning the domains from the most individual level of micro-level theories through the meso or social level theories to the macro or societal level theories, to answer a broader range of research questions than we could do with either quantitative or qualitative alone, to understand hidden or emerging populations where we really need both methods to get an initial understanding of with whom we're working, to explain disparities among populations, to understand unexpected findings that come from one type of research or another, to meet translational needs between populations for health research. The strengths of one method can offset the weaknesses of another to produce stronger evidence. We use mixed methods to develop instruments, to validate instruments, and to develop interventions for emergent problems. Here are some major verbs in mixed methods research. The major functions are to triangulate, or to converge, corroborate, or validate results from different methods. To complement, here is where we want to elaborate, enhance, or further illustrate or clarify the results of a method. To develop, as I mentioned on the previous slide, to use one method to develop the other method. To initiate, to look for new perspectives, contradictions, and again here the intention is to obtain divergent, multi-perspective information, and to expand. Mixed methods are used to expand the breadth, depth, and range of the research, resulting in more comprehensive results and a broader scope of study. Now, at the core of mixed methods, as we're discussing today, is the qualitative mix. So what do we look for from the qualitative component? Mainly, inductive methods in our qualitative research will allow for the identification of previously unknown processes, explanations of why and how phenomena occur, and the range of their effects to pursue in-depth understanding. Quantitative, mainly deductive methods are ideal for measuring the pervasiveness of known phenomena and central patterns of association, including inferences of causality. They test hypotheses or theories. They gather descriptive information to pursue generalization, group comparison, and replication. Here's a graphic to show us all the full spectrum of the mix that we just talked about. And as you can see, in the middle is the pure mix, which probably none of us actually really use. But to the left is pure qualitative, to the right is pure quantitative. And we can have mixed methods research all along this continuum. What are the methods in mixed methods? So this is not by any means an exhaustive list, but just to give some examples. On the one hand, in the qualitative domain, in-depth interviews, ethnographically informed field observation, patient notes from which we can abstract themes and language, along with surveys of attitudes and beliefs, epidemiological measures, such as measures of prevalence or the percentage of a population that's known, for instance, to be below the poverty level, or other types of measures, patient records, archival documents, and clinical trials forms. How do you mix methods? How does this mixing, what form does it take? In one form of mixed methods, we merge the data. We report the results together in one discussion section. And sometimes we use qualitative data qualitatively and quantitatively, and sometimes use quantitative data qualitatively. And we may display the results in one table. Embedding is different. Here, qualitative analyses would be part of a fundamentally quantitative project, so that a subgroup receives qualitative interviews in a larger clinical trial. Connecting is still different. Here, the analysis of an initial phase results inform the subsequent phase of data collection. So we have a formative, qualitative, and quantitative data collection phase that can inform an intervention trial or instrument development and use. And again, these are just examples here of the different types of ways that we can mix methods. Here is an important graphic that shows us the parameters that we ought to keep in mind when we're choosing a mixed methods design. So in one column, we can see the timing parameter, where things are concurrent, things are sequential with qualitative first, or things are sequential with quantitative first. Then, as I showed you in the graphic before, there's weighting. There's whether our elements, our components are going to be equal or predominantly qualitative or quantitative. And then there's how are we going to treat the data? Are we going to integrate it? Are we going to connect it? Or are we going to embed it, as I discussed on the previous slide? And then another parameter to keep in mind is whether there is explicit theory or mission that we have from the very beginning of the work, or whether there is implicit theory that emerges from the work. Now, I'm going to use those parameters to walk through 6 types of designs that we can use for mixed methods research. And since you're going to see them in a minute, I'm going to go on now and deal with the first type, which is sequential explanatory design. Here, the quantitative study is initial, supplemented by qualitative study to explain the quantitative results. And I'm going to put on my glasses for a moment because I want to give you some more details that are on this slide. So what we're talking about is an extremely important study in PrEP, or pre-exposure prophylaxis research. This is the VOICE trial, vaginal and oral interventions to control the epidemic, which was a randomized clinical trial which used both concurrent, embedded, and sequential explanatory designs. I'm going to emphasize how this uses a sequential explanatory design, but I do want to emphasize to you that it also used concurrent mixed methods. So the main event in this study is a clinical trial of over 5,000 women in 3 countries, Zimbabwe, South Africa, and Uganda, in 15 different sites. Here, there were 3 active arms: tenofovir oral PrEP, Truvada oral PrEP, and tenofovir vaginal gel, each of which had placebo arms, for which there were 2, an oral and a vaginal placebo arm as well. And the goal of this study was to obtain information about the effectiveness of these modalities for pre-exposure prophylaxis or preventing further HIV acquisition in women who were HIV negative. Unfortunately, the results of the RCT showed that no active arm was effective in preventing HIV acquisition in high-risk women. Very importantly, the main trial also showed that the women weren't using it. In the oral arms, not in the oral arms, but in the detection in plasma of the tenofovir, there was an only 25% rate of detection. And in the vaginal swabs for the gel, there was only a 49% rate of detection of tenofovir. This, mind you, is all the while in self-report and other measures, which I will show you, of the women who ardently participated in the trial, less than half disclosed non-adherence or barriers to using these agents. The situation was serious enough that way prior to when the trial had anticipated stopping, in September of 2011, oral tenofovir was stopped, and in November of 2011, the vaginal gel tenofovir was stopped. Now, these results were startling and fall into the category of unexpected results, and the investigators, led by Marazzo and also by van der Straten, had anticipated the need for mixed methods. And it was not for lack of trying that they still couldn't quite get a handle on why there had not been use and why of these agents and why there had not been report of non-adherence. And I just want to point out to you that they also used face-to-face interviews. They used ACASI, or audio computer-assisted interviews, for surveys that were administered to the women. And they also used counts of pharmacy-returned products, in addition to pharmacokinetic, or I've already mentioned the plasma levels of drug in plasma, and also pharmacokinetic levels of active drug in vaginal swabs. Despite this, they still needed to pursue further in qualitative methods how the situation ended up this way. And I'll just say, in a multi-method study of 472 women in this trial, they found that by behavioral means, only 10% reported low or no use, whereas non-adherence in the oral drugs was up at 69% in the sense of not detecting the drug, and 65% in terms of not detecting the drug in vaginal swabs. So, further on in the VOICE trial, they did do very extensive, elegant, they did use qualitative methods. They used in-depth interviews. That was one interview per participant, and they used these methods with participants, with a small sample of male partners, and also with community members. They used what are called serial ethnographic interviews, or more than one interview with a female participant along the way. They also used in-depth interviews with male partners, focus groups with male partners, and they also used focus groups with the community members, including community members who had been part of a community advisory board and other community members. And here they were able to identify themes that informed these perplexing results. I'm going to highlight the major themes that they found. And the first one is that there was confusion about antiretroviral treatment as treatment or as prevention. even though women had been thoroughly informed in the rigorous informed consent process about what the purpose of the study was, once in it, they got confused or had ambivalence about using an agent for PrEP, which is also used for treatment in HIV-positive people. Even though folks were told that these ingredients, these agents that are used for HIV treatment, are in the vaginal gel or in the tablets that they were taking, it turns out that not all the women discussed understanding that this was the case. So this treatment prevention confusion was one of the key themes uncovered in the qualitative interviews. Second was stigma. There was major concern on the part of women about being identified as HIV positive because they were using the same agents known to be the treatment for HIV positivity. So they concealed their use of the products, they hid them, and ultimately their sense of stigma outweighed their sense of the possible benefit that they could get from either of these products. Occasionally, this sense of stigma and some revelation to significant others about their taking PrEP ended in relationship strain, and sometimes it caused them to leave the study prematurely. A third theme was their ambivalence about the treatment. Was it efficacious, or was it going to cause them harm? Was it going to cause harmful side effects? And really, this resulted in a sense of ambivalence that encompassed both their feeling like this could be life-saving and that this could be harmful, that they could even acquire HIV from using these agents. And finally, another theme, because out there on the street in their communities, ARV, or the agents used for treatment of HIV, was sometimes sold in the same venues and transactions as were drugs of abuse. So there was also a subjective sense of what were they going to be associated with criminality. The last study that I want to talk about before I move on from voice is one that came later, taking a backward look, a retrospective look at what possibly could have happened. And here, from an anthropological perspective, a dynamic of the clinical trial actually in some ways mimicking the dynamics of power in the mainstream society, such that the clinical trial apparatus and the folks conducting it became the powerful other, to whom the woman, usually indigent, often oppressed, often not having access to the kind of care, incentives, and regular high-quality health follow-up that she received in the trial, the dynamic became one of, I've got to be a perfect adherer. I've got to say that I'm doing the right thing. Otherwise, I'm not going to be able to continue to access the high-quality follow-up that I'm getting, which may be the only high-quality follow-up that I get in the medical domain. And I'm not going to be able to access the incentives that were, although reasonable in amount, were much needed by these women. So again, to get back to the sequential explanatory design, the reason I've lingered in this particular study for quite a bit of this talk is that it's a very important study. It has very important results, and it yielded very important lessons sequentially, which finally helped to understand what these unexpected results in the RCT were. Now, the next design that I'm going to talk about is the sequential exploratory design. And here, a qualitative study is initial, followed by a quantitative study which builds on its findings. And I want to showcase here the Healthy Living Project, which was a behavioral intervention that actually focused on 3 different domains of adjustment among HIV-positive individuals. It took place in Milwaukee, Los Angeles, San Francisco, and New York, and LA. It encompassed 936 people, and they were randomized either to receive the Healthy Living Project intervention immediately, which I will describe briefly, or to be on a waiting list to later receive it. These were HIV-positive people it started out to be 3 different groups. 1, injection drug users, 2, women, and 3, at first, as you can see on this slide, men who had sex with men, or MSM. But as the study progressed, and inklings of this were in the initial qualitative phase, it turned out to be true that there were a considerable number of men who did not report having sex with men who were also HIV positive. So the study expanded to include men, women, and injection drug users. Although in the male risk group, most of the men, but not by all means, not all of them, were men who had sex with men. This was an intervention that had a 1-year qualitative formative phase before it, which consisted of in-depth interviews with people from these populations, as well as providers and focus groups, to try and develop the intervention, the assessments to be used in the intervention, and clearly, as I've said already, to be able to best define the sample. What ended up as the intervention, because of the challenge of spanning 3 risk groups who were living on such different terms, was a 15-session intervention divided into 3 modules. Each module was 5 sessions, and very importantly, and let me just say about these modules, 1 covered improving quality of life and could be said to be the mental health module. 1 covered risk reduction, and this would mean helping HIV-positive people to not engage in behaviors that could possibly transmit HIV to other people. And then 1 that focused on enhancing health behavior, including retention in care, including adherence to antiretroviral medication and other behaviors. And very importantly, the qualitative data showed that although you could use a central theoretical model, which by and large turned out to be a cognitive behavior therapy informed intervention, and although you could use a uniform structure for the intervention for all of its participants, which included trigger identification, so when triggers for problematic behavior could be identified, then problem solving could take place and skill building could take place. And for all of these activities, it was very important that individuals identified a compelling goal that made the work that they were doing in these behaviors worthwhile. The qualitative data showed that although you could use a uniform theoretical orientation, and although you could use a uniform structure for the sessions, that to honor individual differences, you needed to tailor the work that was actually done in these domains according to the meanings, the context, and the priorities of the individual. Just to round this out, this was a trial that successfully showed that the intervention group had fewer HIV transmission acts than the control group, all the way out to 20-month follow-up, which was 8 months after intervention. And among those who started out with less than 85% adherence to their HIV antiretroviral treatment at baseline, the intervention group had 10% greater adherence than the control group at 15-month follow-up. So now I'm going to move on to the next design, which is sequential transformative design. And here, the important difference between the sequential design that I've talked about before and now is that at the outset, there is a theory-driven or mission-driven design in which an initial phase provides fundamental data to craft the second transformative action phase of the design. If this sounds like jargon to you, let's go to the real example. And this is the so-called PROMISE study, which was a quasi-experimental trial of a community-level HIV risk reduction intervention, guided from the very beginning by, and this is why we call it mission-driven or theory-driven, by a trans-theoretical model of behavior change, theory of reasoned action, social cognitive theory, and diffusion of innovation theory-driven intervention. I know that's a mouthful, but the important principle here is that after consultation among experts, it was and careful review of behavior change literature, it was decided that the most efficacious interventions would follow these time-proven models for behavior change. However, a very painstaking and worthwhile formative phase preceded the final design of the intervention and the conduct of the trial. So let me tell you a little bit about this. Over 3 years, there were over 15,000 individuals. About 8,000 were in the intervention communities, and about 7,000 were in the comparison communities. This was a quasi-experimental design, which in 5 cities, Dallas, Denver, Long Beach, New York City, and Seattle, included 10 intervention and comparison pairs of units. Therefore, to take New York as an example, there was a pair of housing projects, one the intervention housing project and one nearby the comparison housing project. They were both included in the study, and at 4-month waves over 3 years, through street-based intercepts, there were cross-sectional surveys delivered to people who were eligible for the study. So we had a quasi-experimental design that was going to compare among these serial cross-sectional samples what the percentages of self-reported risk behavior were over time, as the intervention communities or units got exposed to the intervention, and for the most part, the control or comparison communities or units did not. Now, the people involved in the study were variously injection drug users, women who were female sexual partners of injection drug users, female commercial sex workers, or other types of women who exchanged sex for drugs or shelter or money, high-risk youth, men who had sex with men, or in one city, residents of high STI census tracts. Now, let me describe the intervention to you. But first, let me tell you, how did we arrive? How did the investigators, which did include me, arrive at the intervention? So you heard about how there was a theoretical basis for it, but then a very detailed community identification process occurred. And this was according to the work of Toshima et al. First, community documents like annual reports from agencies and community needs assessment were reviewed. Then individual interviews, focus groups, and observation took place. The individual interviews encompassed key participants, so these are people who had the same characteristics as the target populations in given cities, system interactors, who are formal service providers. So these were people who were selected because they delivered direct services to these populations. Gatekeepers, who were informal service providers. I'll give you an example. In the housing projects of New York, we talked with an informal gatekeeper who was an older person who was often in the courtyard of the housing project, who was known by everyone to know everything about the housing project. Another example could be merchants in the local bodega. And we also did individual interviews with project staff. Focus groups were conducted with, again, people who are from the population we were targeting, and also with project staff. And then brief surveys were done in the neighborhoods. And this helped us to determine very briefly the rates of risk behavior occurring and to ask questions that discriminated between risk behavior with main partners versus other than main partners, and risk behavior that involved vaginal versus anal sex, the two most effective ways to acquire HIV without protection, because this information was going to be essential to knowing whether the populations that we were targeting actually would endorse and report having considerable frequency of these behaviors. In addition, and very importantly, ethnographic observation was used to determine where we could find these risk populations and at what time of day and at what day of the week. And from all of this formative work, which was mixed methods, because we had a number of qualitative modalities that I've described, but we also had brief surveys which were quantitative, we were able to determine that the intervention which we were entertaining, which was based on moving people from a pre-contemplative stage of change about using protection to an action or even maintenance phase of condom use, was going to be viable, that the modalities that we were thinking of, which were going to be homegrown small media, so these are newsletters created by a core group of people from the target population that would have in them role model stories that would narrate the journey of a risk of a person at risk from feeling pre-contemplative about protection to taking action to use protection. So the intervention became outreach and distribution of newsletters that were made by the target population that narrated the role model journeys of people just like themselves from various stages of not caring about protection to caring about protection. And indeed, this intervention turned out to be efficacious as well in moving a far greater percentage of people in the intervention condition from pre-contemplative to active stage of change than in the control condition. And I might also add that another important outcome, although a secondary one, was people being able to show us that they were carrying condoms. And we also saw a far greater percentage of people carrying condoms in the intervention condition than in the comparison condition. So here is an example of a sequential transformative design in which we knew what our mission and our theory was to begin with, but a qualitative formative phase drove the later quantitative trial phase. Now we come to the next design, which is a concurrent triangulation design. And here, the study concurrently collects both qualitative and quantitative data and identifies convergence, divergence, or their combination. For our example, I'll just briefly describe the rapid assessment, rapid response, and evaluation, or RARE, method, which, under emergent AIDS conditions, this design used concurrent multiple methods: community advisory board discussion, qualitative focus group and key informant interviews with diverse stakeholders, and ethnographic observation, street intercept surveys, and mapping and geocoding to obtain triangulated data to generate rapid HIV prevention programs in 3 hard-hit cities. I know that was also a mouthful, but the real take-home message here is in the throes of the early AIDS epidemic, hard-hitting Detroit, Miami, and Philadelphia, the National Institute on Drug Abuse thought it necessary to use a rapid assessment, response, and evaluation design to get the lay of the land, particularly on people at risk via drugs who also had sex risk, and to be able to inform next action steps as soon as possible. So the combined qualitative and quantitative methods that I've read to you from this slide were used concurrently. And just to give you a flavor for some of the results, so the results were organized into people, places, and times. And in terms of people, it was found through all of these methods that important at-risk people to target in prevention programs were injection drug users, particularly those who were crossing over to engage in risky sex as well. Non-injection drug user, crack cocaine folks who were also engaged in sex risk, commercial sex workers, and important outsiders, meaning the dealers who came into prime neighborhoods to sell, and the customers and the pimps who promoted the sale of sex and the sale of drugs. Through ethnographic observation, it was pinpointed that especially at certain times of day, unoccupied buildings, deserted cars, parks, and stores, the very same stores that might sell products that were useful for health, were also in the back rooms, stores where drugs were sold. were key places where interventions should take place. Very notably, you don't see here that the health and social service agencies were places where this rapid assessment method recommended prevention should immediately be brought, because it was determined through ethnographic observation that those folks weren't frequenting enough those very well-meaning services that wanted to provide those services, but perhaps weren't yet adequately reaching the folks most in need of them. And then time was very important. In this article, there's a very interesting figure that shows that the time of day where risk is the greatest, which is from sunset to sunrise, is the very time of day when service delivery is the least. So if you're going to bring services to the folks who really need it, this assessment concluded that you've got to shift the hours so you're reaching people most in need at the times when you can reach them. So I'm going to just give you an example without much explanation of two more designs. There is the concurrent embedded design, which consists of a primary qualitative or quantitative approach concurrently supplemented by a secondary quantitative or qualitative approach. And here is an example of the Pathways study. Pathways was a longitudinal, primarily quantitative study of linkage to care among newly diagnosed people living with HIV in South Africa. It used an embedded qualitative interview in a subgroup of newly diagnosed people living with HIV at the same time that the main actions of the trial were taking place. So the work done in this study was to look at the impact of not having a day of diagnosis CD4 blood draw on the time it would take to link to HIV care. And the results showed that 72.5% had no same-day CD4 blood draw, and 19.2% of them never returned for care. By 4 months, the study was able to look at the rates of linkage to care among those without that day of diagnosis CD4 blood draw and those with it. The people who did not have the day of diagnosis CD4 blood draw, 54% of them did ultimately link to care by 4 months. This was in contrast to 75.2% of them who linked by 4 months, those people who had a day of diagnosis CD4 blood count. So the message here is that I won't go on to describe the results from the embedded qualitative interviews, but the take-home message here is that another way to do this work is to do the work concurrently, but to save the labor and yet get a very rich information from the qualitative interviews. Use embedded qualitative interviews on a subgroup of people in the intervention. Now, my last design that I'm going to talk about is concurrent transformative design. And this is where there is already a mission, or again, a theory or a target expectation in the thing being studied that concurrently uses quantitative and qualitative, there is an error on this slide, I apologize for that, methods to obtain data about a target critical intervention policy or topic. And here, I'm just going to mention a very elegant study called Art for All in New York City, which concurrently uses multiple methods, that is geospatial quantitative analysis of municipal surveillance data, quantitative analysis of people living with HIV in a cohort, and qualitative interviews with people living with HIV and primary care providers to evaluate progress in the rollout of universal ART in New York City. And I would like to say that I was also a member of this study, although not its leader. And what's very important here is that this study already had in mind that ART, according to national policy and municipal policy, ART, or antiretroviral treatment for everyone diagnosed with HIV, was already rolling out. What was intended here, what the mission was to be able to quantify that rollout and to understand in terms of meanings of immediate ART for both providers and for people living with HIV, to understand the underpinnings of participation in this rollout. So we've got our 6 mixed methods designs. We have the many functions of mixed methods designs that we've talked about already. When we obtain the data, how do we put it together? And so there are, of course, as we talked about, many different ways or variations for mixing the data in analysis and synthesis. And what you see here, here we are talking about parallel data collection and analysis and summaries, triangulated analysis and summaries, where we're not parallel anymore. We're going to actually mix the qualitative and the quantitative data together. And to take that even further, sometimes applying quantitative methods to qualitative data and sometimes applying qualitative methods to quantitative data. And so just to give you an example of that last line, there are times after we uncover the major themes in qualitative data where we may look at what's common, so how frequently are certain qualitative themes endorsed and how rarely are they. And similarly, we may have quantitative data that tells us about frequency, but using a combination of quantitative methods and qualitative interpretation, perhaps we are able to construct an overarching construct which thematically combines variables that we discover to be related and is able to characterize them in a more meaningful, overarching way. So what you see on this slide is the rows depict different phases of handling data, and the columns depict different methods usually used for quantitative and qualitative data, respectively. So for preparing the data, for the quantitative data, we're coding and assigning numerical values, and in qualitative data, we're organizing data and transcribing text. For reviewing and exploring data, we may be carrying out descriptive analyses for trends and distributions in quantitative data. And in qualitative data, we're reading data and notes and developing qualitative codes. For data analysis, we are using appropriate statistical tests. And in the qualitative data, we are coding data, assigning labels, and using analytic frameworks, grouping data, and looking for related themes. And in representing the data, of course, we're often accustomed to seeing figures, tables, and graphs for quantitative data, and we're accustomed to seeing qualitative data presented in text form, sometimes in visuals. So if you can imagine the possibilities of not doing these separately, but as the 3 bullet points, as actually 2 of the 3 bullet points above inform us to be able to triangulate them. So we present them in our discussion and in our reports, shuttling between the qualitative and the quantitative to inform one another. Of course, nothing comes for free, and there are not only strengths but weaknesses in conducting mixed methods research, and you see a whole array of them here. I'm just going to focus on the weaknesses here because I think I've probably spent the whole time talking about the strengths, and it can be difficult for a single researcher to carry out both qualitative and quantitative research. Especially if 2 or more approaches are expected to be used concurrently. And it's going to take a village to do this. A researcher, whether they're doing it themselves or not, has to learn about multiple methods and approaches and to understand how to mix them appropriately. It is more expensive, likely, to use mixed methods, and likely it is more time-consuming. And I think I'm going to skip the rest of the bullets because I invite you to look at the slides yourself and go to the last slide, which I think reiterates why mixed methods have been important in HIV biobehavioral research. And I hope, as I've tried to show from the examples of studies, mixed methods research, beyond what can be done by qualitative and quantitative alone, have helped us to identify, access, understand, and collaborate with hidden populations at risk and in need at some very important junctures in the HIV epidemic. We have been able to develop original tools, interventions, and approaches for important unmet needs for these populations. We've been able to assess the impact of interventions in terms of aggregate effects, theoretical expectations, and underlying meanings and contexts, as well as their variations. We've been able to assess the impact of innovations in practice or policy from different vantage points, frames, or perspectives. And we've been able to explore and explain knowledge gaps, contradictions, and counterintuitive findings in research. So thank you very much.